In the anesthesia justice system, pre-anesthetic visits are considered extremely important. At the University of St. Francis, the dedicated anesthetists who investigate these patients are known as members of an elite squad known as the GSRNA class of 2020. These are their stories.
So what do we got?
Good morning, Detective Chief.
It's iced.
Oh, sorry.
Iced tea.
Okay.
Looks
So-
like we got ourselves a 55-year-old male opening inguinal hernia repair. Smoker, 35 years to life. COPD over 13 years ago, but is only on average 2 puffs twice a day. What you thinking?
I'm thinking we got to bring in our big guns for this one.
You're right. See who I can call up.
See who's
I think we're
available.
going to have to get Lori on the case.
Miss Jackson, if you're nasty.
Hello? Yeah. I was gonna call tonight. Yeah, I'll be right there. Okay, bye. Hi there. Be right with you, okay?
Hi there.
Hi.
How are you? I'm Lori. I'll be your nurse anesthetist today. How you feeling? We're gonna do some questions here before we get started and go to your surgery.
Okay.
All right. You're having a hernia repair today.
I guess.
Okay. All right. So, let's talk about your history a little bit. Okay.
Yeah.
All right. So, any problems with surgery before?
Oh.
No. Okay. Family history? You didn't eat that donut, did you?
No. My family brought that for
Oh,
after.
okay, all right. And the
After.
drink too? That's not yours,
No,
right?
no.
When was the last time you ate anything?
Yesterday.
Yesterday.
Definitely yesterday.
Okay, all right. Let's also talk about some of your medications. What are you taking right now?
One of the.
Something for your breathing,
Yeah.
an inhaler.
Mhm.
Do you know the name of it?
Nope.
Okay, all right. I think I saw on your chart that it was Advair. Does that ring a bell?
Could be.
Okay, all right. So does that help you with your breathing?
Sure.
Sure, okay, all right. If we need to give you something in surgery, we'll do that, but otherwise we'll just see how things go, okay?
Puff, puff, but don't pass. Always ask about rescue inhalers. Is it effective, severity, and duration?
So you have COPD. Are you short of breath often? Like when you're just day to day doing your daily activities?
Maybe sometimes.
Okay, all right. Are you ever coughing anything up or coughing a lot?
Yeah.
Oh, that was this morning?
Mm-hmm.
Great. Okay. All right. Very good. Well, does that happen often?
Daily.
Daily. Okay. Okay. So, you said you get up and around a little bit or not a lot. What is your activity like? Can you
I like
walk
to
up a flight of
watch Judge
stairs?
Judy,
Oh.
and then I'll get up and I'll get lunch. I
Okay.
usually get short of breath with my walker.
Okay. Using a walker.
Yeah.
All right. You move everything okay? Pretty normal?
Mhm.
All right. So just the shortness of breath sometimes is what gets you.
Mhm.
Okay. All right. What about heart history? You said your family had some cardiac history.
I didn't say that.
Okay, so you yourself do not have any heart history? Okay. And your baseline today, your breathing, is that about how it is every day? Yeah. What about snoring?
Yeah.
Yeah, you snore a lot.
Mhm.
Okay, so, you're married? Are you married?
Yeah.
Okay. Does your wife ever tell you or nudge you and say, hey,
Oh, yeah.
hey, stop snoring, fella?
Mhm.
Okay, all right.
Welcome back to American Idol. Ryan Seacrest here, and I'm here with our next contestant, William Hung. William, how are you?
I am very good. Thank you.
Awesome. So, are you a professional singer? You are so good. What do you do for a living?
Oh my gosh, thank you. No, I have no professional training in singing. I am full-time CRNA, and I always know that it is important to stop bang.
Okay, whatever that means. So, can we just get a little preview snippet of what you're going to be singing today for the judges?
Yes, I am going to be singing my remade version of Ricky Martin's song. I call it Stop Bang.
All right, let's do it.
She stopped bang, she stopped bang. Oh baby, she stopped bang, she stopped bang. It's important to stop bang, stop bang. Yes, you got to do your assessment when you stop bang. She stopped bang, she bang. Oh baby, when she moves, stop bang.
All right, well, I feel like that's an instant hit. What do you guys think?
To assess for increased risk of sleep apnea, we use our stop bang questionnaire. The S stands for, does your patient snore? Do they get tired often during the day? Have they had observed periods of sleep apnea? Are they being treated for high blood pressure, or do they currently have high blood pressure and don't know about it?
For the B, that stands for BMI. Does your patient have a BMI higher than 35? The A stands for age. Is your patient greater than 50 years old? For neck, that would mean greater than 17 inches for a male and greater than 16 for a woman. For G, gender would be male, would be a positive sign.
At the end of your questionnaire, if your patient has 4 or more of the indicators, then that means they are positive for having an increased risk for having sleep apnea. So as you can see, our patient snored. His BMI was 34.8, so we went ahead and gave him a positive for that. His age is 55, so he's over 50. His neck was 18 inches, so it's over the 17, and he is also a male. So this patient will be at increased risk of sleep apnea, and we would adjust our plan to account for that.
Another assessment tool that we use in pre-op is the Bones assessment. This helps us identify patients that might be difficulty in mask ventilating. So our first is beard. Does that patient have a beard? O stands for obesity, which is BMI greater than 35. If the patient has no teeth, if the patient is elderly, and S is if the patient is snoring. So our patient is obese because they're close to about that 35 of BMI, and he also snores. So that kind of gives him an increased risk for difficulty in mask ventilation.
So I'm going to go ahead and give you a listen here, okay? Heart and lungs and all that good stuff. Will you be able to sit up at all in a minute, or
just get this out of the way.
Yeah, there you go. Perfect. Okay. All right. Just take some deep breaths for me, in and out. All right. A couple more. And again. And one more time. Why don't you give me a big cough? Good. Okay. I'm going to listen to your heart. And a few more deep breaths. Last ones. And one more. Thank you. All right. You sound pretty good today. I'm going to do my airway assessment. So it's going to help me decide if I'm gonna have any troubles when we're putting in your breathing tube today. Okay, so go ahead and open your mouth for me. Stick your tongue out, but don't say ah. There you go. Good job. All right, any trouble with your jaw? Moving your jaw around or chewing? Go ahead and open that for me. Perfect. All right. Feel your neck. What about your movement? Can you look all the way back at the ceiling? Okay, so go ahead and look up at the ceiling for me a little bit. Any trouble with your neck moving around side to side? Okay, all right. Go ahead and open up for me. I'm just going to take a look here and see. Good job. All right. And I'm going to feel your neck a little bit. And go ahead and swallow for me. All right, good. All right, good deal. Okay, so that just helps me decide as far as our breathing tube, or when we give you some oxygen before we put in the breathing tube, if we're going to have any troubles with that. Okay?
Okay, so looking at our patient, we see that on room air, he is 92%, and his respiratories are 22, which makes us suspicious that he has some decreased respiratory effort. So when we assess him, we're going to listen to his lung sounds. There are several different lung sounds that we can hear. We're going to expect to hear some coarse rhonchi with COPD. This would also be seen in infection and malignancies. Other lung sounds that we can hear are crackles, which would indicate fluid in the alveoli, CHF, pneumonia, and fibrosis. We could also hear wheezes. They would be musical sound. They can indicate airway narrowing or inflammation. Differential diagnosis could be asthma or vocal cord dysfunction.
And when looking at these, the importance of assessing for adventitious breath sounds is to make sure that we know how it impacts our ventilation requirements post-op, our fluid status. It could be reflective of our overload, and our overall effects on the plan based off of what breath sounds they present with. Also important to note is that this patient has obstructive lung disease because he has COPD for 13 years, and he's also obese, which is a form of restrictive lung disease. So given those two criteria, it is important to do a full and complete airway assessment to highlight any additional risk present in this patient. Another thing we want to hit on is him being a smoker for 35 years. We want to promote and do some patient teaching to promote smoking cessation and educate him on the benefits of doing such. Benefits can occur as early as 24 hours with returning carbon monoxide levels to normal, but preferably we'd like to quit for up to 8 weeks to get their risk normal to a person that doesn't smoke. Also, as we can tell, our patient is quite the blue bloater, so we want to make sure that we've looked for his chest shape. He has a barrel chest. His nail clubbing. Does he have a diamond? If not, that indicates that he has nail clubbing, and those are all positive signs of his chronic bronchitis.
An indication for spirometry for this patient would be hypoxia, severe symptoms of his COPD, chronic oxygen use at home, which he does not, and it's rarely indicated with restrictive disease. Another test that we can do in pre-op or in PAT would be a chest x-ray if indicated, as well as this patient might benefit from doing maybe like an albuterol treatment in pre-op.
Given this patient's history and assessment findings, we would also be prepared to administer pre-op or intra-op nebulizer treatments to promote the best outcomes for our patient.
So these are the components that we use to do an airway assessment in pre-op. So the first component is the upper lip bite test. So I want to see where the teeth hit on the lip, on the upper lip, if it's at the vermilion border, above, below. The Mallampati, I'm going to have the patient open their mouth and stick their tongue out without saying ah, and I'm going to look at all the structures inside the throat and give that a grade. The thyromental distance, I'm going to have the patient look up to the ceiling and measure with my fingers from the thyroid notch all the way up to the border of the mentum. So that's usually about 3 finger breaths. I'm going to assess for TMJ, so I'm going to put my fingers here right above the tragus, or right in front of the tragus, and have the patient open and close and see if there's any clicks or if it gets stuck ever. I'm going to assess the neck by having the patient look up and down and side to side to see the range of motion for that. Tracheal position, I'm going to make sure that it's midline. I'm also going to assess if there's any kind of masses or anything abnormal in the soft tissue. I'm going to check the interincisor. So when the patient usually opens up for the Mallampati, I'm going to make sure that I can get at least 2 finger breaths between the teeth. Also, when I do that, I'm going to look at the tongue to make sure that it's not too big. And also, I'm going to also look for missing or loose or chipped teeth, so the patient doesn't lose a tooth.
All right, so just going to go over a couple more questions about just other systems and make sure we're not going to have any troubles. Kidney troubles? Any problems with urination? Okay, we're doing that just fine. How about diabetes? Your blood sugar was fine, so I wasn't too concerned about that. Okay. And arthritis? You move around okay, everything bends and okay, all right. And what about acid reflux? A lot of people have that issue. Any troubles with that?
Not that I know of.
Good, okay. And then sometimes people get nauseous from some of the medicines that we give during surgery. Do you have a propensity to get motion sickness? No? Okay, all right. We'll give you some stuff anyway, but that's kind of part of our plan, but just like to identify that as a risk. So no other significant medical issues that you can think of. And I wanted to ask you about chest pain because we didn't discuss that earlier. Chest pain when you get short of breath? Okay, all right. And then in your hands or in your feet, do you get any numbness or tingling? All right. And I wanted to go ahead and feel some of your pulses here in your feet. Do you get any edema, any swelling here in your legs ever? No? Okay. All right. Well, I think everything looks good. We're going to get you back there and get you all hooked up. And I'll let you breathe some oxygen for a little bit, and we'll get you off to sleep. We're going to take really good care of you. Do you have any questions? No. Okay. All right. I'll see you back there then. Okay? Okay, gang. So in conclusion, we identified some of the priority risks for this guy. Obviously, has the potential to be a difficult intubation. So plan would be maybe difficult intubation cart, glide scope in the room for sure. Probably not an awake fiber optic, but those could be some of the other options available. Wedge pillow. Impaired gas exchange, COPD, and pre-op, we're going to assess his needs for albuterol, maybe before or after. And then we want to talk with the patient about the need for potentially using a ventilator or BiPAP post-operatively, just depending on how severe his COPD is. And this is a moderate risk surgery. It is an open abdominal or inguinal hernia. So we want to educate in pre-op if we have the time about turn, cough, deep breathe, and use of incentive spirometry.